and good morning, everyone. Thank you for having us here. It's Department of Orthopedic Surgery's turn now. With great pleasure, I'm introducing my colleague. She's a dear friend of mine. She's an orthopedic surgeon and lecturer in University Malaya for the past 6 years. She has a special interest in congenital hand and feet differences. She recently completed her fellowship in pediatrics hand surgery under Professor Jean Shen. She's a world-renowned congenital hand surgeon from Children's Hospital of Suzhou University, China. Without any further delay, I invite Dr. Khoo Sian to present her talk on debunking the myths in common congenital hand differences.
Thank you, Prof. Jaya, for the kind introduction. Last year, I had the opportunity to further pursue my passion, like what Prof. Suresh said, that makes me really happy. I managed to do a fellowship with my idol, Dr. Jane Shan. That would not be possible without the support of Prof. Jaya, because she single-handedly helped to the fort, single-handedly hold on to the whole unit, because we are really short of staff now. So she made it possible for me, and I would like to thank her for that. So when we talk about hand anomalies, so it can happen to the thumb, the hand, and the fingers. There are too many to cover for this topic, but the most common one is radial polydactyly, which is extra thumb. And the second most common one is syndactyly, or fused finger, web fingers. In Asians, radial polydactyly is probably the most common, but if in US, probably syndactyly is more common. So the first myth that most of the patients, when they come with their parents, the mother always thinks that it's something that they did or something that she has done during her pregnancy that caused this deformity. So the hand anomalies caused by intrauterine teratogens. So usually it's not what the mother did or did not do during the pregnancy. Although some have genetic causes, some have no apparent reasons at all. So pregnancy and anticipating a baby is a happy event, but when they found out during the baby is delivered, they usually have a lot of questions in mind and they are lost. Did I do something wrong? What will happen to my child? Can he or she do things like other children do? So how's the world going to look at him or her? Is she going to be bullied? So is my next child going to be affected as well? Can all this be fixed? And who should I look for help? So this all comes to referring to the right team at the right time, so that first we manage the parents, give them the information, and secondly, we deal with the patient himself or herself. So the parents need to be empowered, given the knowledge of what is the correct diagnosis and what is the surgical plan and what they can anticipate, so that they are prepared, so that they will not be the child first bully. Why do I say so? Because from my experience, a lot of time, especially when I was in China, where having hand deformities is very much a taboo. So the parents usually will keep the child at home, refusing the child to join any social activities, or they even will cover the hand with a socks when they go out. So this inevitably tells the child that something is wrong with you. So, and you are not welcome to join the public. So the second myth is, the more severe looking the deformity, the poorer the function. So if you look at these two pictures, which one would you think have better appearance? So my children, 6 years old and 3-year-old, both have a look at this picture, and they only ask me what happened to the picture on the right. So which hand has better function? So if you look at it, one hand on the left does not have a functioning thumb. It's a floppy thumb. So we call it a hypoplastic thumb. And the one on the right is a lobster claw hand. So, but the one on the right actually has much better function. The thumb itself provides 40% of the hand function. So the child can do almost everything, just like you and me, but just that it doesn't look good. So the more severe looking the deformity does not necessarily mean the poorer the function. So we must first know the pathoanatomy, and we must assess the joint, muscles, and tendon, and we must also tell the parents about this. So number 3, hand anomalies are not well accepted worldwide. So interestingly, this study, when they show pictures of hand anomalies to few countries, and they ask them to rate which one they think is better looking. So between the Europeans and the Asians, so the Europeans tend to prefer having 4 fingers rather than 6, while Asians prefer to have extra fingers, 6, rather than to have 4. So again, if we look at Asia alone, so it makes a whole lot of difference whether you are in China or in India. Because like I say, in China, it's very much a taboo. They feel that the child comes from the parents, inherits the things from the parents. So if the child has a deformity, means the parents usually have done something really bad. And it's something like, what do you call that, a repercussion. So in India, otherwise, it has some sort of like spiritual meaning to having finger deformities, foot deformities. They think that the child is unique and is gifted. So, and this man in Cuba, he has 24 fingers and toes, and he has no problem doing his daily activities, and he's very happy. He thinks that he's blessed, and there are people who come and take photos with him, pay him money, and he's happy. He's making a good living. So there's a lot of cross-cultural differences and religious beliefs. When we counsel patients, we have to be mindful of that as well. So the myth number 4 is children heal poorly after surgery. So this is what I always say about kids. They are like Wolverine. Why? Because they have very, very good healing power. Their wound just heal in no time, most of the time. And they have very good regenerative ability. Their bones heal, their tendons heal, their ligament connections heals very well. And they are very adaptable. They learn very fast. And they have grit. Try telling your child not to do this. They keep doing it. So myth number 4, hand reconstruction surgery can only be done when the child is much older. So this is something that led me to give this talk, because a lot of times when I see patients in the clinic, then I wonder, why do they come so late? Why do they only come now? But a lot of time the mother or the father told me that, we have sought someone else advice, but we were told to, there's nothing can be done until the child is much bigger. So that really misses out on a lot of opportunities and things that can be done for the child. So before we move on, we need to know, to understand congenital hand, we need to know how the limb form. So the critical time is between 4 to 8 weeks, where the limb bud starts to form, multiply, migrate, and differentiate. And from then onwards, 8 weeks to term is where it starts just to grow. So this used to be very confusing to me, but to make it easy, okay, so from the limb bud here, so what happens is the growth will go from proximal to distal, and it will also ulnarizes and also dorsalizes. So these 3 axes in a 3D dimension will form the upper limb, and the critical timeline is between 4 to 8 weeks. Any insults during this time would cause deformity. So if, let's say, it is the proximal distal a path that is affected, the axis is affected, then you can have transverse deficiency. So if it's the anterior posterior pathway, radial ulnar pathway, then what you can happen, if it's too much of it, you can get ulnar dymelia, too many hands, mirror hands. So if it's a dorsal ventral axis, what you can get, you can have something called what do you call that, a dorsal dymelia, where you have nails on your palms. So this classification has been adopted and is constantly evolving, because what we know about congenital hand is just really the tip of the iceberg, and new knowledge has been added, and which led to this classification being updated every now and then. But in general, this is a very detailed classification, but in general, it is divided into these 3. Malformation is what happens during the 4 to 8 weeks during the abnormal formation. So deformation is any insult that occur after it has formed. And dysplasia is just something totally different, just like tumor. The limb just grow abnormally in size, shape, and the cells just enlarge. So the common one of all the congenital hand anomalies is radial polydactyly or duplicated thumb. So this is the classical vessel classification that we use. It has 7 types. So the odd numbers are bifid duplications, and the even numbers are complete duplications. But because we are looking at more and more different types, and they can't all fit into this classification, which led to the Rotterdam group to come up with a more comprehensive one. And I'm sure in the future there will be more and more different classification as we discover more. So of all these, type 4 is the most common. Type 4 can also be divided into 4A, 4B, 4C, 4D, and I can give a one whole day talk on that. So surgical goals for radial polydactyly in general is to achieve a single stable mobile thumb with good appearance. So if you look closely at this picture, these 2 thumbs, the right and left, are never exactly the same. So instead of what they call a duplicated thumb, is more correct to say that it's actually a split thumb. So in assessment, generally, it's very important to look at the web angle to see whether web widening is required, because that will affect the patient grasp, and also to check for the stability of the metacarpal phalangeal joint. So in this patient, which has a type 5, so the ulnar collateral ligament instability in the MCP joint is common. So, and another common mistakes that lead to poor surgical plan and also poor outcome is the X-ray, because a lot of time the X-ray is ordered very early in the days, and it was not repeated. And number 2, wrong view is ordered. A hand AP view can never see the thumb in a true AP position, because the thumb is not lying in the same plane as the rest of the fingers. So the true AP view, PA view of the thumb is what is shown on the picture on the left. So as you can see, the joint surface is so different from the one of the X-ray that you can see in the hand PA X-ray. So that will affect how you manage the joint. So if you understand the fetal anatomy, then the result will usually be good. So also for different, it's not just cutting the thumb all the time. So it depends on the types. You have different type of procedures that might be warranted. So usually we would like to have a thumb that is at least 70% of the other side, so that it can provide you with good pinch strength. In general rule, if that's both the thumbs are abnormal, then you look at the index fingers. So the thumb should be bigger than the index finger. So this is a combination procedure where you combine 2 distal phalanx together, compared to the the original Debunking procedure, where they combine it at the joint level, right at the center. It causes more problems like nail ridges, and it doesn't look pleasing. So this method by Beck from Korea is a much better alternative. So the advantage is you can have a bigger thumb, more stable interphalangeal joint, and you will preserve the radial collateral ligament, and that causes less risk of deviation. So this is a highly skilled procedure. If it's not done properly, you will have unsightly nail ridge. And in surgeons sometimes who are not so confident in doing this, they might choose just to keep a smaller thumb rather than to have a very unsightly looking thumb. So the preferred timing to do this is actually from what I learned from Dr. Sian is 18 months, so that you can have a good approximation of the nail bed. So in certain types as well, you, instead of combining the 2 digits, you can just use the soft tissue from one side without taking the bone, and to augment it or to make the thumb look bigger. So in this case, where this is a type 4D deformity, so the surgeon actually needs to also rebalance the flexor tendon. And this commonly, in some cases, are not done, in which it will cause residual deformity. So in some cases where the neither are good enough, so we might combine it, and it's called on top plus A, or I call it a mix and match procedure. So possible complications, okay, not all cases need to be done after 1 year old. Some cases are quite urgent. For example, in this case where this floppy digit is twisted on its own stalk, then surgery has to be done. But if child that are born with floppy digit like this, sometimes the lay people will always advise to use a what do you call that, a string to tie around it, the stalk, and let it drop by itself. So this is also possible if because anesthetic risk is in a very young child is quite real. So what happens is you can just let the finger drop off first, and then but there will still be a nubin at the side, which can be dealt with later on. The nubin is important to deal with because not only because it's not pleasant looking, but also because usually it's associated with a nerve end that can cause neuroma. So in small thumb like this, it will look like, oh, it's so easy. We can just, just chop it off and it'll be okay. But attention has to be paid to removing the nail bed properly, and also the nerve that goes to the little extra thumb. Otherwise, you have painful neuroma, and also after some time, you might have nail coming out from the side. So common causes of reoperation radial polydactyly. The first most common reason is prominence. That is very common in type 4 deformity, where there is failure to deal with the metacarpal bone to reduce the bone and to do a corrective osteotomy. So, and then the second type is deviation, about 34%, just like I mentioned just now in the type 4D, where tendon rebalancing was not done. So the other one is instability. So this can also happen in cases where, for example, on-top-plasty is required, but instead the surgeon just choose to remove the radial thumb. That would cause this. And another one is the one that I mentioned just now, the BC procedure, where it was not combined properly, and it will cause this unsightly nail deformity. So these cases are all referred to Dr. Shen, but it was not her own cases. So the next one is thumb hypoplasia, is relatively not too so common. Causes unknown. It can be associated with some other syndromes and also associated with radial longitudinal deficiency. So the question is whether we reconstruct or we polysize. It depends on how much the thumb is deficit. If it's not stable, the general teaching is to polysize. Polysize means turns the index into a thumb. It generally gives very good function. It's certainly advisable for type 5, where you totally do not have the thumb at all. And the preferred timing is about 1.5 years old. So, but with the advances in, microsurgery, good microscope, and surgeon skills, so there is a possibility to actually, for the type 3B, you can actually reconstruct. If the child is less than 3 years old, you can actually use one of the metatarsal bone without taking its blood supply and just reconstruct it for the thumb, and it will grow well. It has shown that it will grow with time. So, but if it's more than 3 years old, it's advisable to bring along the artery and veins. So another one is transferring the whole toe to the thumb to make up for a totally absent thumb. So this would be advisable at the age of about 5 years old to ensure that you can get it right the first time. So syndactyly, another common one is what we call fused digits. So it can be simple, just a soft tissue, or complex involving the bone as well. Ideal surgical time is actually 6 months because the child is smaller, and also the soft tissue is they have more skin, and there's less chance that you will need skin graft. But 1 year old is a good give and take because of the anesthetic risk if you do it in a very young child. So older child tend to need skin graft, and if let's say more than 1 digits are involved, you may require state surgeries. Usually we separate the sides fingers first because they are of different heights or lengths that will cause them to so-called deviate if we don't deal with them in timely manner. So there are also other syndromes that can be associated with this. Apert syndrome and Poland syndrome are the common ones. So these are some of the cases that I have done after I came back from my fellowship. So this child is actually quite about 3 years old. And the mother was very hesitant about the surgery because she's worried about everything from the scar to the anesthetic risk. And even after admission, she was still thinking whether to proceed or not. This all happened because the patient, when they come to us at a very late age, and then you immediately advise for surgery, that's what happens. So if they see us much earlier, and then you prepare them ahead, then they will be able to accept it much better. But after the surgery, the mother is very pleased and she's very happy to see the result. So the next one is macrodactyly. Local gigantism is not hereditary and is very rare, and it usually correspond to the nerve innervation. So most of the cases, the child will have limited range of motion of the joint. So it may be associated with some syndrome as well. So what we usually do is we will debulk it as necessary, one side at a time. And sometimes if the nerve is very, very big, we may need to excise it. If it's not too bad, we can actually cut it and then reattach it so that we can so-called reduce its function. And then wait until the digit has reached the same gender parent size. Then we will fuse the epiphysis. Occasionally, we might have also need to cut the bone and reduce the size. So amputation is only when it's unsalvageable, and usually it's because of late presentation. So, and this is a case where this child is 17 years old. She first came to see us when she's 17 years old. And it's not her parents' fault because her parents has been going from one doctor to another doctor to seek for advice. And but she has all sort of tests run on for this child, and eventually a diagnosis was made, and she came over. So, and in our unit we also do food. So the ideal timing is 10 months old. Why? Because before the child start to walk, it is very difficult to immobilize the child when the child starts to learn and want to walk. So it's better just before that. So usually the outcome also is very good and it's quite straightforward surgery. So the general flow is first clinic visit, we will do investigation, establish the diagnosis, reassure the parents, tell them the surgical directions and do the necessary referrals. And pre-op clinic, we will reconfirm the surgical plan and check the parents' understanding. Admission for surgery is usually about 3 to 4 days. Post-op for about 1 month, and where we will remove the cast and the wires. Rehabilitation involve splints, compression garment to reduce the scar, and also therapy, which is usually play therapy. And scar management is usually up to 6 months for better looking scar. So, and then we do yearly review. So I like to finish off with one case. This child, this child has Apert syndrome. So she has one of the more severe form, which we call rosebud hand. So if just at one look, you don't really know which one is the thumb, which one is the little finger. And she also has other problem that is associated with Apert syndrome, like cranial synostosis. She had her first surgery with us at 1 year old, and also few subsequent surgery to stage release of the fingers and also the feet. So this is her now at 3 years old. So she can eat independently on her own. She can play and learn. She can do her activities, her hobbies. And she can also do some life skills. So many conditions cannot be fixed by surgery, I agree. But for those who cannot, they actually, they have a power. I mean, the child have a very huge potential. It's not like adults who lost their limb from an accident and all. Children who are not born with some parts of the body, the reorganization in the brain sometimes makes the other parts of the body more useful to them and more sensitive. So the child that you saw just now is a Nick Ujik. He has a tetra amelia syndrome. He was suicidal in childhood because he was a victim of bully, but he was inspired by the school janitor and say that he has potential to become a speaker. So he actually became a motivational speaker and evangelist, and he's married with 4 children, normal looking ones. So the future is not green because in China, actually, they have this fetal anomaly prevention plan. So most of these patients with anomalies, and also that we think that might be some genetic cause to it, they will all be sent for next generation sequencing gene typing, and then because they are collecting all this data, and in the future, hopefully, there will be options for gene therapy. So the conclusion is the right surgery at the right time by the right team does improve function, but all this will not be possible without very supportive parents. So thank you very much. I will, and I'll be happy to take any question.
Thank you very much, Dr. Khoo. That was a very informative lecture. Thank you very much for bringing up the myths about the myths about hand deformities. It's not only the patient or the parents. We clinical professionals also sometimes believe in all those myths. So let me see if there's any question and answer. Okay, so far there's no question. I would like to ask 2 questions.
Mm.
You did mention that you would suggest surgery at 18 months old. May I know when would you prefer to accept referrals? Because some parents can be very anxious. They will bring their child when they are 1 month old, 2 months old. So when would you prefer to accept referrals? And I would also like to know what will happen if you do the surgery later on, maybe after 3 years old or 4 years old.
Okay, thank you for the question. Yes, this is something that is really close to my heart. Sometimes I get very angry in the clinic, but yeah, I would like to get the referral the very moment that the diagnosis is made, the very moment that the anomaly is detected, because sometimes there are some slight differences that the clinician who are probably not so familiar with congenital hand might miss out. For example, a constriction band syndrome and Sian brachydactyly might look the same sometimes. So, but they are very different. One have completely normal proximal structure, like the constriction band syndrome, but Sian brachydactyly have abnormal structure proximally. So that makes the plan different, whether what you want to do next for them. Okay, so when we get to see the patient early, even after delivery, after confinement, maybe that is maybe fair enough, because it's not fair to bring the child out when the mother is on confinement. So then we can tell the parents, deal with their feelings, let them ask questions, tell them what we can do. Then they can go back, they can read about it, they can think about it, they can look for second opinion, and then they can decide, and they can plan when do I need to take long leave, when can I, arrange for some care for my other children so that I can bring my child for surgery, and then what can I expect after the surgery? What is the downtime? How long do I need to be off from work? This kind of thing. So usually I would say 1 year, but certain procedure that we need more meticulous surgery, then I think 1.5 years is okay. Longer than that, sometimes, for example, syndactyly, you will need to have a skin graft from the groin, and skin graft will cause, the color from the skin graft will be very obvious on the hand. So another thing is, if let's say they are older, they are not so keen to use their hand if you give them something new. So let's say they do not have they are used to use they have a so-called what do you call that, a hypoplastic thumb or something like that, and they are not used to using this hand, and even if you give them a new thumb, they will not use it also. They will find it very difficult to relearn. They are comfortable using the other hand, they will not use it that much, so it will take a long time more to rehab.
Okay. Thank you very much, Dr. Khoo. There's a question here from Prof. Chan. What do you do if a child with this anomaly is detected in utero and the parents want advice for further management, especially if they insist on aborting the child?
Okay. That's a very good question. Uh, there are some things that we can treat while in utero, for example, constriction Down syndrome, but not to my expertise. Maybe we have to ask the fetal maternal specialist. But for the other things, like in Malaysia, termination of pregnancy is not uh, legal for for causes just simple like syndactyly, radiopolydactyly is not legal. But in China, in some parts of the world, for example, in Hong Kong as well, part of China, termination of pregnancy because of fetal anomaly is legal. So, and there was a study that looked into all this, and they found that the parents are more willing to accept a child with congenital heart problem compared to a child with a congenital hand problem. So that it was actually quite shocking. So this is how appearance is very important to them. And their country also have this fetal anomaly prevention program. So all this termination of pregnancy is allowed. So for my side, I think unless it is something that is very severe, I think the child has a lot of hope with the current surgical management that we can offer.
There's one more question from Dr. Lutfi. Do we have the setup for effective post-operative rehab?
Oh yes, I would say our rehab team is very, very good. Puan Farida is very cooperative with my demands. I was in China, I look at how they have a very special compression garment. I'm asking her whether we can do this and that. Yeah, they are very innovative. They're cooperative with us, and they see the patients all the time. I'm very thankful to them for their support. Yes, we do have a very good team.
There's no more questions. I think we can end today's session. Thank you very much, Dr. Khoo Sian, for the wonderful lecture. Both the lectures were great today, and I hope everyone will stay happy and joyful. Have a good day, and thank you very much.
Thank you very much.